Okay, this is the last mini lecture for Module 8 opioids. This is treatment-related drugs that we'll be talking about. There are some key definitions to know going into this conversation. Agonists, there are 3 types of effects that substances can have on neurons. They can be an agonist, which would bind to the receptors and would stimulate the release of neurotransmitters. So there are certain drugs, naturally occurring and synthetic drugs, which will bind to the receptors and release neurotransmitters. It will activate them. There are also antagonists, which bind to receptor sites but don't activate them. They kind of block them. And then there are partial agonists, which bind to receptor sites and activate them a little bit. So it's not the full-blown action that you might get with another substance, but it kind of tickles it more than sort of sends it flooring. And so in opiate treatment for opioid addiction, there are 3 different types. There's treatment of overdose with naloxone, also called Narcan, and this is an opioid antagonist. I'm going to go and talk about all of these drugs in a moment, but this is an overview. Treatment of opioid addiction, so that's overdose treatment. Then there's treatment of addiction, and that's with maintenance programs. There's 3 options there: methadone, which is an opioid agonist, buprenorphine, which is a partial opioid agonist, and Suboxone, which is a combination of buprenorphine and naloxone or Narcan. And then there's prevention of opioid dependence developing, which is used with naltrexone, which is an antagonist for opiates. So we'll go through these one by one a little bit. Naloxone or Narcan is used to treat opioid overdose. It's an antagonist, so it blocks the drug from reaching opiate receptors, and it also knocks off any opiates that are already bound. So it reverses the effects of opiates in the body. If naloxone is taken and the person hasn't done opiate drugs, basically nothing happens because it binds to the receptor sites, but it does not stimulate them because it's an antagonist. Naloxone can be injected into the bloodstream or sprayed into the nostrils, and no inhalation is necessary. It can be absorbed through the mucous membranes. It used to be that this was almost always administered in a hospital ER or by paramedic medical professionals, but we now have versions, specifically the nasal spray, that anyone can administer with a brief training. And in fact, there's a big push and a big public health campaign to get folks to carry Narcan on them. Anyone can be trained in this. You can get prescription Narcan. It may be available without a prescription as well. Don't quote me on that. I'll double check that. But you can keep it with you, and it can save a life if you notice someone overdosing. This is a substance that will literally reverse the opioid overdose and bring someone back from dying. It can work very well unless someone has taken too many drugs or too many combined drugs like other sedatives or other barbiturates. So if someone has just taken an opioid, this works really well. But if they've taken other drugs that slow down the central nervous system, naloxone doesn't work on those receptor sites. And so that may be a case where Narcan isn't going to do much. This is a time-sensitive treatment, though, so it must be administered quickly before the effects have really taken too strongly of a hold on the person. And this is really important. The effects only last for 20 to 90 minutes. So that person needs to get to the hospital immediately, because while the Narcan only lasts for 20 to 90 minutes, the opioids, like we mentioned a moment ago, are generally in the system for about 4 to 6 hours. And so you can give someone Narcan, they can kind of pop back up and you brought them back from the brink of death. But after 20 to 90 minutes, that opioid is still in their system and they need to get to the hospital to be treated. So in terms of treating addiction, there are a couple options. Again, this is designed to help the person deal with withdrawal symptoms and deal with craving, which again, as I mentioned before, can be main motivators behind someone who's relapsed or continuing to use, is avoiding withdrawal symptoms. And methadone is one way to treat opioid addiction. It's a long-acting synthetic opioid. It's an agonist. So it binds to the opiate receptor sites and it activates them just like heroin would. The only difference is that it lasts for far longer than heroin does. It lasts for about 2 to 3 days. I'm sorry, 1 to 3 days. It reduces drug cravings, it blocks withdrawal symptoms, it really is effective in avoiding those problems that come with getting off of heroin. However, like heroin, methadone is addicting. So it's a full opioid agonist. It functions in much the same way. But it does have a slower absorption rate, so it's longer lasting. And it has a decrease in HIV transmission risk because it's taken orally. So there are benefits to a methadone program. And because it's slower, like the absorption is slower, there isn't that same intense rush, intense high that users report when they inject heroin, for example. So it may be producing the same kind of pain relief and numbing effects, but it's not associated with that classic euphoria kind of state. Methadone has been prescribed more often in recent years as a pain reliever, and so there is some increase of the street availability of this substance, which is, again, people use it sometimes as an alternative, straight up alternative to heroin. There's also a real risk for overdose with methadone. Methadone was responsible for 1/3 of all prescription painkiller deaths, but it is the least prescribed. So it is disproportionately responsible for deaths among people taking painkillers. And that's because of that long-acting nature of it. People don't realize that the methadone is still in their system. They take more opiates, or they have either more methadone or a different type of opiate, and that suppression of the breathing, lowering of the blood pressure leads to death. I mentioned that this is what I was talking about a moment ago. So that long-acting nature of the drug, people don't realize it's still in their system. And so because of the risks associated with methadone, this drug must be prescribed and supervised. So people who are in a methadone program, they cannot take the substance home with them. They have to consume it in front of a doctor. And so they're given it in a like a little plastic cup like you would take medicine in, and the doctor has to watch them drink it. An alternative to methadone is buprenorphine, and the name brands would be Subutex, Suboxone, and Butrans. This is a partial agonist, so it activates the opioid receptors, but to a lesser degree than something like heroin or methadone. It does provide some pain relieving sensation, so an analgesic effect. It helps for something like chronic pain, for example. It has a very high affinity for opioid receptor sites, so it binds to them quickly and very strongly, but it only minimally activates them. And it blocks the receptors from other opioids. So because of this, it has very minimal abuse potential, very minimal overdose potential, and it's doing the things that we want. It's reducing the cravings, it's reducing the withdrawal because it is binding to those receptor sites. So buprenorphine can be prescribed by any doctor, and supervision in a drug treatment center is not required. This really is the first step now in treating opioid addiction medically. Another substance that's been developed recently is Suboxone, which contains buprenorphine, which we just described, that partial agonist, but it also contains Narcan. And the reason that this formulation was developed was to prevent people from crushing up buprenorphine and trying to get more of an intense pain relief effect. So I mentioned a moment ago that it only really minimally activates those opioid receptors, but if it's taken in a way that has a quicker absorption, the user can experience that little bit of a high. And so pharmacists have added Narcan to buprenorphine, and basically buprenorphine Narcan cannot be absorbed through the digestive tract. So if the pill is taken normally, the Narcan isn't activated. If it's placed under the tongue sublingually, Narcan isn't activated because it can't be absorbed that way. So it really is only if somebody crushes up the pill and tries to inject it, then the Narcan will prevent the buprenorphine from working. So both Suboxone and methadone prevent physical withdrawal and minimize cravings. Treatment with Suboxone generally doesn't start until the client is entering active acute withdrawal. If begun earlier, it will throw the client into withdrawal because it will compete for the opioid receptors. So the person has to start detoxing before you would introduce buprenorphine. And naltrexone is the opioid antagonist. And what happens with naltrexone is it's given either in pill form or as a long-lasting injection, and it's given before the person ever takes any opiate. And then what happens is it binds to the opioid receptor sites, it does not activate them, and it prevents any other opiate that enters the system from binding to them. So it basically prevents someone from getting high off heroin. It's a substance that you give, that they take before they ever use the drug, and while this drug is in their system, they cannot experience a heroin high. So this is sometimes given to people who are interested in recovering from addiction might volunteer to take this substance so that they can't relapse. But more often what's been happening is this has been prescribed or mandated by drug treatment of incarcerated persons. So people who were in prison and who are being released on parole or probation, they've been mandating that they take naltrexone as a way to prevent their resumption of their heroin habit. And there's a lot of ethical debate about whether or not that's something that the court system can mandate, which we won't get into. But really, what I want you to know is that this is a opioid antagonist, and that as long as it's in the body, the person cannot get high from any other type of opiate.